Namaste. Warm greetings from all of us at Apollo Hospitals. This is Dr. Srinidhi Chidambaram. Welcome to our FB Live session today. Many a time, it is the lack of knowledge about our body and health that lands us up into severe health complications. This is why we at Apollo Hospitals have been consistently having these sessions on Facebook to give you the best of factual information from our experts who are, of course, top specialists in their respective fields. COPD, which is chronic obstructive pulmonary disease, is a group of progressive lung diseases, and this is what we are going to discuss in detail today. The most common of the varieties of COPD are emphysema and chronic bronchitis. And basically, in all these conditions, for example, in emphysema, the air sacs in the lungs are slowly destroyed, interfering with the airflow. And there is in bronchitis inflammation and narrowing of the bronchial trees and the bronchial tubes, allowing the mucus to build up. And all these conditions, if untreated, can lead to a faster progression and also several other complications of other organ systems, and ultimately can be life-threatening as well. COPD, in fact, was the highest cause of death in India after heart disease in a study done in 2017, killing almost 1 million Indians that particular year. And it can be caused by a variety of reasons, including lung irritants, toxins in the air, as well as smoking. And in India, of course, it is also because of exposure to indoor and outdoor air pollution. There is no cure as such for COPD, but there are several advancements in the treatment. So it is important to understand what the early symptoms are, seek medical help at the earliest. And it is also important to know what the latest treatments are and what the innovations are in the management of COPD. To explain this to us in detail, today we have with us Dr. Sai Praveen Haranath, and I'm delighted to welcome him. Dr. Sai Praveen Haranath is consultant intensivist and pulmonologist at Apollo Hospitals, Jubilee Hills, Hyderabad. And he's the medical director of one of the first tele-ICU programs in India called the E-Access. With an American board certification in internal medicine, pulmonary and critical care medicine, and also an MPH and FCCP, he has over 20 years of experience, has also received several awards such as the Humanitarian Award from UCHC and the Governor's Community Service Award from the American College of Chest Physicians, completed the John Hopkins Bloomberg School of Public Health Tobacco Control Leadership Program, and has been involved in research presentations at conferences in India and abroad. His prior experiences in rural community and academic medical centers in the US, and the most recent engagement at the Permanent Medical Group in the San Francisco area, his tele-ICU experience, and his current position at Apollo in Hyderabad make him an expert in helping patients with complex medical conditions, including COPD. Welcome, Doctor. Thank you so much for joining us today. And let us first begin by telling our viewers what exactly is meant by COPD and what is it all about, really?
Sure. Thank you, Dr. Srinidhi. I think at the crux of it, when you can't breathe, nothing else matters. I think we all know that when you're exercising, walking upstairs, you can't catch your breath, you really realize, oh my God, your breathing is really important. For patients who have COPD, chronic obstructive pulmonary disease, this is a daily challenge. For them, every day is like you're walking up the stairs and you can't catch your breath. Now, in reality, COPD is very preventable. Most of it is caused by exposure, as you said, to all kinds of air pollution, which could be induced by yourself, including tobacco exposure. In addition to that, smoking, BD smoking, cigarette smoking, or indoor pollution, for example, people cooking indoors with wood fires, exposure to air pollutants from factories, industries, all of these can cause that. Now, one of the shocking things that I have seen in my practice is 50, 60-year-old women coming in with lungs that look like they've been smoking all their lives. And this is perhaps due to indoor air pollution and also could be due to secondhand smoke exposure from their husbands and their parents and their other relatives. So this is a silent epidemic that's going on. And during this COPD Awareness Month and with the World COPD Day, we try to highlight the fact that their lungs were never more important. Now, with the COVID crisis, we have seen how important the lungs are. And if I can just briefly touch on what the human lung does, it's a remarkable organ. In fact, if you stretch the human lung out, as you know, it kind of opens up to the size of a tennis court, almost 75 square meters. And that entire surface area, it exchanged gases. Oxygen comes in, carbon dioxide comes out. So when you're breathing normal air at sea level, the oxygen comes into your nose and mouth, goes in through your throat, and then ends up going right into the air passages. Your airways then split about 23 times, and they go all the way towards the air sacs. And as you rightly put it, and you give an excellent summary of what happens in COPD, these air sacs get damaged. And why do they get damaged? Pollutants have poisons in them which actually destroy lung tissue. They destroy the collagen, they destroy the material in the lung itself. And when that happens, you end up with loss of lung capacity. So the tennis court size lung can drop all the way down to a table tennis table. And you can understand the difficulty in exchanging gases. Now, luckily, the human body has a lot of adaptations. So it can do things like increase your hemoglobin, which carries oxygen. It can also make you breathe faster. You may be starting to walk slower, so you're not consuming so much oxygen. And in addition to that, sometimes the heart beats faster to pump the blood more. So in COPD, you get a bunch of changes. And if you obviously stop smoking or decrease your tobacco intake, you end up with quite a bit of benefits related to that. Now, one other thing that we need to realize is that patients end up with difficulty in breathing, not just because of COPD and not just because of the difficulty that they're having related to the loss of lung capacity, but they also lose muscle power. They lose muscle. It's called sarcopenia, where their muscles start breaking down. And if you have a comorbid condition like diabetes or heart disease on top of that, because all these can happen in tobacco too, you end up with compounding the problem. So the big picture lesson is COPD is preventable. It's good to detect it early. And as you rightly mentioned, you can have destruction not just of the lung sacs, but the air tubes get swollen, just like an asthma in a way. But here they become permanently damaged and you end up with difficulty related to mucus buildup and getting stuck in there. So I'll pause there. There's a lot of things you can talk about. I'm glad to listen to your other questions too.
For a person who may be slowly getting a COPD, what are the earliest signs? Because this is something which, people talk so much about diabetes or BP or heart, but one never really, as you said, think about the lungs until, you really become breathless. So
Sure.
what should a person be really aware of? And is there any kind of a screening that they should do every year or anything to detect this earlier?
Sure. So I think one of the things we do in our hospital system is really well is screening, and I think preventive health is so important, and you yourself have been a proponent of that. And I think it's critical for us to realize that everybody loses lung capacity. Your best lungs are when you're really young, and then you start losing about 30 ml of lung capacity every year. And when you smoke, you lose it much faster, much earlier. And recent data has even suggested, unfortunately, that babies in utero who are exposed to tobacco from their mothers or others actually have slower development of lungs, they have smaller lungs, and they actually end up with poor lung capacity as they grow up. So this problem starts very early. Detecting is often not easy because it happens very late. But the way to pick it up is doing something called spirometry, which is the criteria used by the big global organization called the Gold COPD, where they've done screening using spirometry. Essentially, you blow into a tube that measures your lung capacity and how fast you blow out. And if that capacity comes less than 70%, it suggests that there is a tendency towards obstruction. I'll give you a very quick analogy to this. Imagine you're blowing a balloon open, and as you blow the balloon gets bigger. But if you have COPD, what happens is these tubes, they kind of get narrow. The air gets stuck inside, doesn't come out. And when it gets stuck inside and doesn't come out, you can't really take a deep breath because there's no space to go on. So that's one of the things that happens. And you see these people with bloated chests and like flat diaphragms. That's because of what's called, the hyper expansion, or it's called hyperinflation. So you take an X-ray of them, you'll see a lot of black stuff, and the black stuff is air because the lungs have expanded out. So one of the things to do is to do a spirometry. And very recently, they've come up with newer tests, which include very advanced things, including doing CT scans of the chest. And in COPD patients who smoke, sometimes they will do CT scans to pick up lung cancer. Now, very early on. Other tests include doing some very high-tech stuff, including inhaling special isotopes and using an MRI even. Now, these are experimental, so they're not out in the mainstream, but people are working very hard to pick it up early. Now, one other technique that people have looked at is using exhaled breath. They measure the components in the exhaled breath. They look for chemicals in the breath and look for chemical signatures. Again, experimental. Things which are available include measuring eosinophil counts in your sputum. So you can actually check the number of eosinophils, which is an allergy cell. It's now the white blood cell has many parts, as you know, the neutrophils, which fight infection. You have eosinophils, which fight allergies. Then you have the lymphocytes, which, as you all know, are important in fighting viral infections. So the eosinophil count, if it's less than 100 or more than 100 or more than 300, you can actually make a determination what kind of treatment you should start. So the eosinophils are something to look for. So this is just very quick overview of what's available and what's coming down the line.
And of course, in our Apollo's preventive check programs, a pulmonary function test, that is the spirometry, is always involved. So I guess if one goes for an annual health check, this would also be automatically looked into.
Sure. I think the data is still not great in terms of saying it 100% makes a difference. But I think spirometry in the right setting with a history of somebody with cough, exposure to tobacco or other smokes, or other kinds of chemical exposures is very important to do. Completely agree.
So is COPD reversible, and at what stage is it exactly reversible, or when do you reach the point of no return?
Sure. See, now, I would want to be hopeful and tell our audience that, there's a cure, but there isn't. But there's a ton of research. I was just looking up the other day, and there's about 5,000 studies going on COPD right now in the world. And in India, almost over 100 studies, I think, just testing different molecules. People are looking at even stem cells for COPD now. They've done experiments with that. People are looking to see if it works or not. So in terms of curing it, there isn't one. In terms of stopping it, the main thing is to stop the actual trigger, and which obviously most often is tobacco exposure, and along with other dust and air pollutant exposure. And also controlling exacerbation. What is an exacerbation? People start producing more phlegm. The phlegm becomes thicker. They start changing color from yellow, green, etc. When those things happen, you can actually end up with lungs getting worse because, like you mentioned earlier too, the mucus can get stuck inside and damage the lung more, and then you end up with trouble. Now, people, just a quick myth buster here. When people see colored sputum, they think it's an infection. Not always. The color of the sputum is green sometimes, and that's because of a chemical called myeloperoxidase, which is in the white blood cells. It tells you that there's also inflammation going on. So a lot of times it may be a non-bacterial infection, and an early detection test nowadays that we sometimes use in high-risk patients is using a very specific PCR technique to look and screen for viruses. We've been using it more with the COVID crisis, just like the RT-PCR for COVID. We have RT-PCR to check for a whole bunch of other viruses and some very specific bacteria we call atypical bacteria. And this can also pick up exactly what may be wrong. Now, these tests are a little bit expensive, but sometimes we need it because we can detect influenza, we can detect respiratory syncytial virus, RSV, and other kinds of viruses, including things like metapneumovirus. So these are some viruses which can cause exacerbations.
So now coming to the treatments for COPD, so what are the conventional ways in which, is there you did say that the cures are all experimental and there's really no current method to cure it, but what happens when somebody is diagnosed with COPD? How is it treated?
Sure. See, I don't want to be, sound hopeless, but there is plenty that can be done to improve the quality of life and actually live a very normal life. I have several patients with very severe COPD who are living completely full and productive lives. And it's detected early. You watch for exacerbations, try to prevent this flare-up that happens. And it's very simple, actually. You just have to kind of have a routine to it. Be in touch with your doctor. In fact, they recommend every 3 months, see your doctor if you have COPD. You can take many medicines. So when you have the air tubes, they can get narrow. And when you give medicines to relax the tubes, just like in asthma, you can relax them. And the way that you relax them, these air tubes have special receptors. I'm sure our audience is very familiar with the receptors now. You know that the COVID virus attaches to the ACE receptor. Likewise, in the air passages, you have what are called beta receptors, then you have what are called muscarinic receptors, and these are involved in the squeezing of the muscles of the airway and relaxing the airway. So you can give very specific medicines which act over either a short duration or a long duration that relax the tubes, which help you breathe better. So you want to get the oxygen in and let the carbon dioxide out. So if your tubes are open and the plumbing is open, the air can come out. The other drug that's very often used is what's called an inhaled steroid. Now, these drugs are very tiny doses, which actually affect only the lungs. A little bit they get absorbed, but most of it is only the lungs, and they decrease the inflammation, the swelling in the air tubes. Some of our audience, I'm sure, studies physics, but there's a simple law where a tube is narrow, the flow gets harder, and it's you need to push harder. Likewise, if you cut the inflammation, the tube gets larger, so air can go in and out more easily. Same thing as when I don't know if you had a thick milkshake lately, but when you have those thick milkshakes, they give you big straws because it's easier to get the stuff in. Same thing with the lungs. If you have a bigger tube, it's easier to get the air in and out. So you get medicines to relax the tubes. In addition, give medicines to cut the inflammation and, of course, treat any infection. Lately, there are newer drugs available which actually work on different mechanisms of the muscles itself and relax the muscles using an alternate system. And lastly, there is new data suggesting that a very common antibiotic, azithromycin, sometimes helps cut the inflammation. And we have seen this in a condition called bronchiectasis, which is very common in India, actually, in lung problems. One of the common ones is bronchiectasis. After TB, you get this where the lungs get damaged, the tubes are larger. In COPD also, they've shown that these drugs in very specific circumstances can be helpful in preventing flare-ups. Rarely people need steroids and oral steroids to keep the inflammation down. And of course, steroids, as you know, have a bad reputation, but you do need them sometimes. Of course, have to watch for infection, watch for glucose, sugar going up, watch for weakening of the bones. These are all very common side effects, ulcers, things like that in the stomach, which can happen. But with COPD, sometimes you need that. When COPD progresses and your lung capacity keeps getting worse, then you might end up needing oxygen from outside. And that might actually be not such a bad thing because you can actually live longer, exercise more, and actually get on with your life more if you actually used oxygen sometimes.
So how does it, what kind of oxygen therapy is given to COPD patients? Do they have to keep a cylinder at home, or how does it work?
Sure. And again, I think with the COVID crisis, we have seen this come up so often. Pulse oximeters, as you know, the little tube things you put on your finger to check the oxygen level, they are something very important. So if your oxygen level is less than 88, then you probably need to be on oxygen, especially when you sleep at night. There have been very large studies for several decades, actually old now, which have shown that oxygen actually helps you live longer, but only if you need it. If your oxygen level is already good, you shouldn't be taking extra. Now, what happens is that there are different forms of oxygen. Oxygen is a gas, but so you need a lot of it, which is why you see these cylinders. These cylinders are actually compressed gas, and they have like several, I think some of them have like 20,000 liters in them. They're all compressed, just like your LPG cylinder for cooking, they're compressed. So when you have a cylinder like that, you can have oxygen, but more user-friendly options are to have something called a concentrator, which pulls oxygen from the air. It converts the air into oxygen, many types and models of that. And then you also have smaller cylinders you can use when you're traveling or when you're actually walking. And we don't have it very widely available in India yet, but you have liquid oxygen canisters which can actually convert the oxygen from a liquid into a gas. When people fly, for example, you need to sometimes use oxygen. And the reason is, even if you're flying at, say, 40,000 feet, that's a common commercial airliner flight, the air inside the airplane is pressurized about 8,000 feet. So it's like having oxygen at an 8,000 feet level, which may be too low for some people with COPD. So often you should prepare for the flight by talking to the airline and your doctor and getting the forms filled out to carry oxygen on board if you need it. So I've had patients travel all the way to other countries using oxygen if they need it. It's not impossible, just need a little bit of planning to be done. So overall, what we've talked so far, Srinidhi, just to summarize, is COPD, we know what causes it. We've talked about how to identify it. We talked about how to treat it. And we've also talked about the advanced therapies. Now, one kind of a thing which may be required in a subset of patients is what's called non-invasive ventilation. Now, people with sleep apnea, I'm sure you've heard of that, and people use these masks called non-invasive ventilators like CPAP, BiPAP, different kinds of machines, and those may be required in an advanced state of COPD, especially when they are lying down and sleeping.
Right. What about surgical options? So we have heard about some patients who do well with certain surgeries, and then we've also heard about some needing a lung transplant. So could you tell us about the surgical options for COPD?
Sure, absolutely. So when I worked in the US, we would have, there was a time when the lung volume reduction surgery was very popular, and it still is being done. Essentially, I'll just give you an example. So imagine a traffic jam. people are going to divert and take other roads to get to their destination. So imagine the lungs are a maze of airways and the air passages end up in these air sacs. If some tubes are not supplying oxygen, meaning the tubes are going to a part of the lung that isn't working, when you breathe in air, some of that air is going to go into this lung which is not working. So that's what we call wasted ventilation, meaning if you have 100 ml of air going, it's not 100 ml, you're probably taking in a liter of air in. Some of it is going to parts of the lung which don't work. So in other words, that oxygen in it is going to a place which doesn't work. So the parts that actually work are getting less. So the logic is that if I cut off the parts which don't get air, then all the air will go to the part of the lung that works, which is a very logical concept. And people have actually done good research to show that it works, that concept works. And you may be surprised, Sunidhi, now that we can actually do this without actually cutting a patient open. So we have this thing called endobronchial valve therapy, which is being done in several of the Apollo hospitals, where you can actually go in, put a tiny piece of a little one-way valve, which what it does is the air goes in but doesn't come out. So it essentially kind of collapses this balloon, which is not working. So you have to do special tests to identify which part of the lung isn't working. You do that test and then you figure out, okay, those aren't working. And there's been some good results using that, where you don't have to actually do any cutting. Even if you do the cutting part, yes, even that is another technique, but the pulmonologists have come up, interventional pulmonologists, and we have several in our system who actually do that. In addition, if that doesn't work, of course, you do need to do a lung transplantation. And our centers in India have done several lung transplants, and very successfully too. And what is important to recognize is that there's a process of lung transplantation. Patients with COPD obviously need to be screened for other side effects. So you need to kind of do the risk balance of, is this patient going to benefit from a transplant? So there are people who have had that done, and many people have had double lung transplants. And one thing we haven't touched on so far, Dr. Srinidhi, is about the effect of COPD on the heart. So sometimes you have patients with COPD, they may have other heart issues related to their smoking, or because all of the blood flows to the heart, then goes to the lung. When the heart's pushing the blood out, the lung is giving more resistance because of COPD, the pressure in the heart goes up. And then you have to manage that problem also. And then people sometimes get bloated because this fluid backs up and you get swollen legs and what we call in technical terms cor pulmonale. And you can have a situation like that. But, we're talking about a subset of patients who have this. And even for this, there is, I think you might be asking me about this later because it's an important part. I'm sure you heard about lung rehabilitation. So I'll pause there and let you ask me more questions.
Yes, of course. I was just going to ask you about pulmonary rehabilitation, and could you explain what it involves, and are there any innovations in it?
Sure, absolutely. So lung rehab or pulmonary rehab is actually using a set of common exercises to build your lung capacity. As you know, the lung is surrounded by ribs with muscles around them. You have the diaphragm, you have the neck muscles. So all of these get weaker in patients with COPD. And if you can actually train these muscles back to work, you can even train people to do diaphragmatic breathing. So essentially, you kind of sit up straight, keep your hand on your chest and belly. Normally, what's happening, our chest is opening up, but you train the belly to start moving out when you take a deep breath. You train the diaphragm to work. And when you train the diaphragm to work better, you can actually increase your lung capacity. That's one example. The other part of this is the adequate diet and the correct diet. In addition, you can also talk about, quit smoking health, because a lot of people, it's very hard to quit smoking. I have patients who smoke on oxygen. It's a huge, huge fire hazard, which is a dangerous thing, but it's such a hard habit to break that sometimes you just need continuous help to do that. Luckily, we have nicotine gum, nicotine replacement. We have counselors in our system, our doctors, pulmonologists, internal medicine doctors, and everybody, in fact, in the health system is always here to help you with quitting tobacco. We have smoking cessation clinics, and in fact, the government of India has a huge, a tobacco cessation department. So I think it's important to recognize that if we can get rid of tobacco, we'll be preventing these problems. Now, lung rehab involves you talking to a trained counselor, talking to a trained respiratory therapist or a physiotherapist, along with your doctor, and they'll train you to kind of get your lungs better. After COVID, for example, we had several patients get treated, and very, very thankfully, we've been able to do remote lung rehabilitation. So telepulmonary rehab, we have done it from our center, for example, and many centers in the world have actually shown that this actually works. So you can do training exercises, Sometimes you do need the patient to come in to make sure that they're safe to do these things at home. But a lot of times you can either send people home or just one visit to the hospital, and the rest can be done remotely. And we've been able to actually show that they're able to do their activities better. And I've had patients who've had improvement, not just with COPD, but other lung conditions too, but they can breathe easier. Some of them are even going off their oxygen. And a lot of it involves hand holding because these things require a lot of support because sometimes you can get depressed and very often COPD patients are depressed. I mean, imagine not being able to do your normal things. Imagine not being able to walk up 10 stairs. And some of these people are in the prime of their life, their 50s, 60s, sometimes even their 40s, and they're not able to do the normal things you take for granted. So I think it's very important that the entire health ecosystem does this. The other thing for our viewers I would suggest is there are definitely going to be family members in your extended family who actually have COPD but don't know about it. And what you could do is look out for people who are kind of short of it when they walk. They may have some obesity. They may be coughing up phlegm all the time and not realize it becomes an unconscious habit. They may be smokers. So there are extended family members, if it's not yourself watching it. There are people in your own homes. It may be your mother, father, because I've seen people bring in their parents because they didn't have problems themselves, but they realize their parents actually have trouble breathing. And especially their mothers, they have trouble breathing. Like I said earlier, they don't smoke, but their lungs are bad. I do a CT scan and I see emphysema there. And I'm sometimes shocked. But luckily, if we can detect it early, there's a lot that can be done.
Absolutely. Thank you so much, Dr. Sai Praveen Haranath, for this wonderful discussion on COPD. And dear viewers, I hope that you enjoyed the session. And yes, to sum up what the doctor said, COPD is a lifelong disease, but better outcomes will be obtained by early medical intervention. And do not worry, even for the most advanced stages of the disease, there are lots of new and effective therapy, lot of options that are available, and you can control your symptoms and you can slow the progression and also lead a very full and productive life. So take medical advice at the earliest. And you know that we are always reachable through our website and through all our social media channels. So we're always here if you have any queries or need any medical advice. So till we meet again, stay safe and stay healthy. See you soon. Thank you and namaste.